Hello everyone and welcome to our module on the skin. The skin is the largest organ in the body. This is sometimes a question on Jeopardy! It's a barrier against infection. We don't think of it this way very often, but it's one component of our immune defense against bacteria and other infectious agents. It also prevents water loss. One of the major problems if you have severe skin damage like a burn is that it can be hard for the body to hold on to water. And the skin is made up of three layers. The outer layer is called the epidermis. This contains cells called keratinocytes, which are squamous epithelial cells. The next deepest layer is called the dermis. This contains connective tissue and blood and lymph vessels. And then beneath that there is the subcutaneous fat, which is also sometimes called the hypodermis or the subcutis. Here's a picture of the dermis and the epidermis is divided into 5 layers. So let's go through those now. So at the bottom of this picture is the dermis that's shown here. It's got connective tissue and blood vessels. The layer of the epidermis that sits right on top of the dermis is called the stratum basale, and we'll talk about that in a minute, but this layer contains basal cells, which are stem cells that can regenerate the skin. The next most outer layer is called the stratum spinosum. It gets its name because you can see little spines along the cell borders here. Above that is the stratum granulosum. This is this layer here with granular cells. Above that is the stratum lucidum, and then on the top you have the stratum corneum. And then here's another picture in cartoon form just to make this very clear. The stratum basale, followed by the spinosum, the granulosum, the lucidum, and then the corneum is on top. So now let's go through these epidermal layers one at a time. So as I mentioned before, the stratum basalis is the basal layer of the epidermis. It sits on top of the dermis, and it contains stem cells that are capable of regenerating keratinocytes in the epidermis. Above the stratum basalis is the stratum spinosum, and this layer has cells with spines, and what forms those spines are desmosomes. These are connections between keratinocytes, and as we'll see in other videos, in some disorders desmosomes are disrupted, and those disorders tend to affect the stratum spinosum significantly. Above the spinosum is the stratum granulosum. These cells contain granules. That's why they're dark in this picture here. The granules are a substance called keratohyalin, and they are used by squamous epithelial cells in the epidermis to form keratin filaments. Above the granulosum is the stratum lucidum. This layer gets its name because it's clear and it contains dead skin cells. It's a thin layer in the epidermis. And then the outer layer is the stratum corneum, and what you need to know about this layer is that the cells in this layer are anucleated. They've lost their nucleus, and we'll talk about later how in some pathological processes you see nucleated cells in the stratum corneum. That is abnormal. And the reason the cells are anucleated is because they're filled with keratin filaments. So keratin is a tough structural protein. It assembles into filaments, and this outer layer, the corneum, is meant to be the tough outer layer of the skin that protects your body. Below the epidermis is the dermis. So if you look at this picture on the screen here, we have the epidermis up on top and then the dermis here. The dermis contains mostly connective tissue and blood vessels, and the fact that it contains blood vessels is important. There are no blood vessels in the epidermis, so processes that cause leaky blood vessels are going to tend to swell the dermis, not the epidermis, because the blood vessels are found in the epidermis. And then below the dermis you have the subcutis or hypodermis. Most people just call it the subcutaneous fat. Now let's talk about dermatopathology. So dermatopathology is an important field in medicine where specially trained pathologists look at skin biopsies and describe the findings that they see, and these are used to make diagnoses of skin disorders. So dermatopathology has a collection of terms that are used to describe the microscopic findings of skin biopsies. Some of those terms are shown on this slide here, so we're going to go through these now. These are all terms used to describe abnormalities you see of the skin when looking at a skin biopsy under the microscope. Hyperkeratosis means thickening of the stratum corneum from an excess quantity of keratin. Remember what I told you before, the stratum corneum contains lots of keratin. So when it becomes thick, you have hyperkeratosis. And this is a picture of hyperkeratosis. It's hard to recognize this if you're not trained in dermatopathology, but the stratum corneum layer here is thickened compared to normal. It's unlikely they'll ask you to recognize a thickened stratum corneum as a first or second year med student, but they may describe this finding and you need to know what it means. And hyperkeratosis occurs in a number of conditions. Psoriasis is a classic condition where thickened plaques develop. Those plaques are from hyperkeratosis. And if you play the guitar like I do, you will get calluses on your fingertips. Those calluses are from keratin buildup in the stratum corneum. That is an example of hyperkeratosis. Parakeratosis is usually seen together with hyperkeratosis, and it means that there are retained nuclei in the stratum corneum. Remember what I told you before, the cells in the stratum corneum should be anucleated. If you see retained nuclei, that is abnormal. This indicates hyperproliferation. It means that cells are moving up from the basal layer into the stratum corneum before they have lost their nuclei. This is seen in a number of skin diseases. You can see it in psoriasis. You can also see it in skin malignancies. And here's a skin biopsy on the screen here. You can see some nuclei in the outer layer here. That is abnormal. Once again, it's difficult to recognize parakeratosis if you haven't been trained in dermatopathology. It's unlikely they'll ask you to recognize it from a picture, but they will expect you to know what the term means. Hypergranulosis, as the term implies, means increased thickening of the stratum granulosum. And the most important and high yield thing to know about this is a classic feature of lichen planus. I talk about lichen planus in the second video on skin disorders, but hypergranulosis is one of the hallmarks of that disorder. Spongiosis means fluid accumulation or edema of the epidermis. This is seen in eczema and many other skin conditions. This is an example of what it can look like on the screen here. You can see these fluid-filled areas in the epidermis. That's an example of spongiosis. Acantholysis means a loss of connections between keratinocytes. It's often a loss of desmosomes that significantly affects the stratum spinosum because, as I told you before, that's where lots of desmosomes are found. This leads to the presence of so-called rounded keratinocytes that are detached and freely floating in the epidermis. This is an example of acantholysis on the screen here. You can see that there are rounded keratinocytes. The layers of the epidermis have separated, and fluid can fill in here, and that often leads to the formation of a blister. And a high yield thing to know about acantholysis is that it's a key feature of pemphigus vulgaris, which I talk about in the video on blistering disorders. Acanthosis is a term used to describe epidermal hyperplasia. It usually means diffuse epidermal hyperplasia. And what this is going to look like on a biopsy is that the rete ridges become elongated. So let's talk about what the rete ridges are. So if you look at this normal skin biopsy on the left, you can see that the epidermis pokes down into the dermis a little bit here. And these edges where it's poking down are called the rete ridges. If you look on the right side of the screen, there's an example of acanthosis, and you can see that these rete ridges are elongated and poking much further down into the dermis. The reason the rete ridges are elongated in acanthosis is because the spinous layer thickens. So what you've got in acanthosis is elongated rete ridges from spinous layer thickening, and it's high yield to know that for your boards. There is a disorder called acanthosis nigricans, and this disorder gets its name because the word nigricans means darkened. So in this disorder, you have epidermal hyperplasia, which is acanthosis, and the skin appears dark. That's why the word nigricans is in the name. So people who develop this condition develop hyperpigmented or dark plaques on the skin. Classically, they occur in the intertriginous sites, which means the folds. So, for example, at folds of the neck or in the axilla, like shown in this picture here. This is an example of acanthosis nigricans. In this person's axilla, there is this darkened patch of skin. This disorder is associated with insulin resistance, so it's often seen in people who are obese or who have diabetes. It's also rarely associated with malignancy. Gastric adenocarcinoma is the most common associated malignancy. So a board question you could see is someone who presents with acanthosis nigricans and has cancer of the stomach. So that was dermatopathology. That was the language that we used to describe findings on skin biopsy under the microscope. Now we're going to talk about skin lesions. This is the language we use when we are describing a rash that we see on physical exam. So if a patient presents and says, I have a rash or an abnormality in my skin, and you examine it, you describe it in terms of dermatology using the language we'll go through in the next few slides. We describe skin lesions as either primary or secondary. So primary skin lesions are those that are directly caused by a disease process, and we use standard terminology that I'll go through in the next few slides. These are words like macules, papules, vesicles, and bulla. Secondary lesions are portions of the skin that have been modified by the primary lesion, or sometimes they are caused by trauma or external forces. So for example, scale on the skin is usually not a primary lesion, it's a secondary lesion that results from some other primary skin disorder. The same is true for crust and erosions and fissures and ulcers, and we'll talk about these as well in the next few slides. Let's start with macules and patches. These are flat lesions. They are not raised. A macule is a flat lesion that is less than 1 centimeter in size. A patch is a flat lesion that is more than 1 centimeter in size. An example of a macule is a freckle. You may have these or know people who have these. These are small, flat, not raised lesions on the skin. An example of a patch is a stork bite. This is a common birthmark found at the back of the neck. It's bigger than 1 centimeter, but it is flat and not raised. And here's a little cartoon just to make this very clear. Macules are flat but small, patches are flat but larger than a centimeter. In contrast to macules and patches, papules and plaques are raised lesions. A papule is a raised skin lesion smaller than a centimeter, and a plaque is a raised lesion greater than a centimeter. A good example of a papule is a mole, which is also called a nevus. This is a relatively small raised lesion that is very common in many people. And then psoriasis is a good example of a disorder that causes plaques. So the lesions in psoriasis are raised. They tend to be larger than a centimeter, so they are described as plaques. And here's another cartoon just to make this more clear. Papules are raised, but they are small. Plaques are raised, but they are larger. Many disorders lead to what's known as a maculopapular rash, and you should understand what this means now based on the skin lesions we've been talking about. A maculopapular rash is a collection of small skin lesions. Some of them are flat, those are the macules. Some of them are raised, those are the papules, and that's why it's called a maculopapular rash. These are also sometimes called morbilliform rashes. The word morbilliform means looks like measles, and that's because measles is one of the classic causes of a maculopapular rash. You can also see these type of rashes in many other disorders. In adults, they're often a reaction to drugs, an allergic reaction, a drug rash. You can also see this type of rash in scarlet fever, syphilis, rubella, and many other conditions. Vesicles and bulla are fluid-filled lesions. The common name for these lesions is a blister. A vesicle is a fluid-filled lesion smaller than a centimeter, and a bulla, the plural for bulla is bullae, is a fluid-filled lesion that is greater than a centimeter. So chickenpox is a classic disorder that causes vesicles. You can see on this person's skin, these are fluid-filled bumps, but they are very small. Bullous pemphigoid is a classic disorder that causes bulla. I talk about this in the video on blistering disorders, but you can see that this person on their arm has very large fluid-filled lesions. And so here's a cartoon just to emphasize these points. Vesicles are small fluid-filled lesions. They often cluster together, like in that example of chickenpox we saw, and then bulla are larger fluid-filled lesions. A pustule is a variant of a vesicle that is filled with pus, so it has a white center. So for example, there is a pustular variant of psoriasis, which involves multiple small vesicle-type lesions, but they're filled with pus, so they appear white. And then many of you probably know, if you've had acne yourself, that many people with acne develop pustules. This is one shown right here on the cheek of this person. A wheal is a smooth, elevated papule or a plaque, and the word smooth is important because that's a key feature of wheals. Wheals are surrounded by erythema, which is redness, and they are usually very itchy. The classic cause of a wheal is urticaria, which is an allergic skin reaction. This is a picture of urticaria on the screen here. You can see these large plaques. These are raised lesions, but what's different from a typical plaque is most plaques are bumpy. If you ever meet a person who has urticaria and you drag your fingers across this plaque, it is very, very smooth. It's also red. That's what classically characterizes a wheal. In addition, it's usually very, very itchy. The cause of wheals in urticaria is dermal edema, and this is a component of urticaria, which is an allergic reaction that I talk about in the video on hypersensitivity skin disorders. Scale is an example of a secondary lesion. It's caused by peeling or flaking of the stratum corneum, which, as you remember, is the outer layer of the skin. Scale is a classic feature of psoriasis. So if you look at this plaque of psoriasis, the plaque has caused a secondary lesion, which is scale, and those are the little gray lines that you can see on top of the plaque. Crust is another example of a secondary skin lesion. Crust is caused by dried exudate from a primary lesion. Impetigo, which is a disorder I talk about in the video on skin infections, is a classic skin disorder that causes crust. And you can see this dried exudate of this lesion of impetigo here. That is an example of crust. I'll finish with this slide and briefly discuss fissures, erosions, and ulcers. So a fissure is a very narrow tear in the skin. There are walls along the sides of the lesion. It can involve either the epidermis or the dermis, depending on the depth of the fissure. An erosion is a wider lesion that involves the epidermis, and an ulcer is similar to an erosion, but it's deeper and involves both the epidermis and the dermis. And that concludes our video on the skin.